All right, so we're going to begin the webinar now. Good afternoon, everyone. My name is Anna Duncan. My pronouns are she, her, hers, and I'm a program operations specialist here at CoLab for Community and Behavioral Health Policy and the Evidence-Based Practice Institute. On behalf of our team, I want to say thank you so much for being here, especially late on a Friday afternoon. So really excited to have you all here today. And we're really excited for today's webinar, which will explore family-based, culturally responsive interventions in child mental health. We will start with a land acknowledgement. CoLab for Community and Behavioral Health Policy and the University of Washington acknowledge that we gather on Indigenous land, the traditional territory of Coast Salish peoples, and specifically the Duwamish tribe. This ancestral land is unceded and must be returned. We also acknowledge that our work across the state takes place on the homelands of Native peoples who have lived in this region from time immemorial. Currently, there are 29 federally recognized and 7 non-federally recognized tribes within Washington state. We express our deepest respect for and gratitude toward these original and current caretakers of the region. As we move forward in advocating for and moving toward health and racial equity, let us remember that we're living in a history-driven present. Oh, can you hear me okay? Oh, okay. Just saw that in the chat. My apologies. Let us work to learn more about the histories, cultures, and traditions of Indigenous people and how we might build relationships with sovereign tribal nations and create more inclusive spaces that foster innovation, collaboration, and empowerment. We encourage you to consult native-land.ca to learn more about the land you are on and to pay rent through Real Rent Duwamish. The Duwamish tribe has yet to be justly compensated for their land, resources, and livelihood. And by paying real rent, you can do something today to stand in solidarity with First Peoples of this land. All funds go directly to Duwamish Tribal Services to support the revival of the Duwamish culture and the vitality of the Duwamish tribe. Before we begin, I'd like to do some Zoom housekeeping. So if you encounter any tech issues, and I know we've already had a few folks talking in the chat about these, please put those in the chat along with any thoughts or reactions to the speakers. And the chat box is highlighted down below. Additionally, we will have a Q&A at the end of the presentation. And so we just ask that you save your content related questions for the end and that you please put those in the chat box rather than unmuting yourself and asking them. It just helps us organize all the questions. And for those of you who have attended our webinars before, you'll notice that we're trying a new format. So we wanted these webinars to feel more connected and to allow folks to have their cameras on, which we love to see your faces and see you engaging with us. So this is actually a giant Zoom meeting rather than a webinar. And because of this, we just ask that you pay special attention to keeping yourself muted because you can easily unmute just because it's a giant meeting. So thank you so much in advance for just paying attention to that. And lastly, as a reminder, this will be recorded and it will be uploaded to our website at uwcolab.org. At the end of our webinar, we will send an evaluation survey link through the chat. So please fill it out with any feedback you may have so we can improve on future webinars. We love to hear from you all. We will also send an email with a link to the recording, slide decks, and the evaluation survey, so you can fill it out later on if that's more helpful. And once you've filled out the evaluation form, you'll have the opportunity to get kind of a general certificate of completion. This may or may not be eligible for credit through your field-specific continuing education organizations. We recognize they all have different policies. We're very happy to provide you with documentation if that's helpful. All right, and before I turn it over to introduce our presenters, just want to take a look at our live poll results. So it looks like out of 88 folks here, 74% are working in the mental health field. So that's a pretty big contingent. And then we also have about 20% working in advocacy, and then kind of sprinkled evenly across policy, medical research, and public health and social work. So it looks like the biggest contingent by far is mental health. All right. So again, I just want to thank you all so much for being here. We're incredibly excited to host this series. And we at CoLab for Community and Behavioral Health Policy are just thrilled to have you. And as previously mentioned, today's webinar will provide an overview of family-based interventions for child mental health. And for those of you who are joining us for the first time, to give a brief overview of what we do at CoLab, we were founded in 2020 within the Department of Psychiatry at University of Washington School of Medicine. The CoLab engages community expertise and research evidence to spark creative and sustainable change in behavioral health policy and systems, specifically those involving youth and families. We believe families and communities have knowledge and expertise that must be leveraged to promote effective, sustainable, and impactful community programs. The Evidence-Based Practice Institute, which is housed within CoLab, was established in 2007 by the Washington State Legislature with the goal of promoting high-quality mental health care for children and families. So for today's webinar, we're thrilled to feature two amazing presenters, Dr. Cindy Trevino and Dr. Janine Jones. So Dr. Cindy Trevino is an assistant professor in psychiatry and behavioral sciences at the University of Washington, and is also an attending psychologist in the Department of Child Psychiatry and Behavioral Medicine at Seattle Children's Hospital. Clinically, Cindy specializes in mental health evaluations and treatment services for early childhood population and providing pediatric specialty services for children and youth with craniofacial differences. Cindy also helped start the Child and Adolescent Latino Mental Health Assessment and Treatment Clinic, CALMA, and now co-directs this clinic, which provides culturally responsive mental health evaluation and treatment to Spanish-speaking Latino families throughout Washington State. So our other presenter, Dr. Janine Jones, is a professor of school psychology and the Associate Dean for Academic Affairs in the College of Education at the University of Washington. Her research focuses on providing culturally responsive interventions in schools, including the integration of cultural factors that are associated with resilience and racially diverse youth. Her work also includes the study of identity and belonging as critical elements in school engagement for youth of color. Dr. Jones is an author and the editor of The Psychology of Multiculturalism in the Schools, a primer for practice, training, and research. She's a licensed psychologist and a nationally certified school psychologist. And now I will hand it over to our first presenter, Dr. Jones.
Hello, everybody. Let me see. Get this, yes. Get my screen shared. Okay, so I am delighted to be here today and to be presenting with Dr. Trevino. This is an exciting opportunity to be able to share one of my passions, and that is on doing culturally responsive school mental health interventions. And why it's my passion is because the way that I was trained in my training programs was not focused on doing culturally responsive practice. And I recognize that that's the experience of many. And so part of what I would like to share with you during this first half hour is what are the reasons why we need to be adapting the interventions that we know, and what are some ways that we can do it. And there are models for doing so, and I'll share a model for you, and then also give you a few strategies that you can use within the context of the model. So culturally responsive school mental health interventions, focusing on adapting evidence-based treatments. So I do believe in evidence-based treatments. But I have to say that in my start that I have a bias, and I do believe that one of my biases is that I believe that cultural factors are the foundation for treatment interventions. So many of us, the things that we learn how to do interventions, we learn the right ones for the problems that are presented in front of us, the social emotional behavioral problems that we see, but we don't necessarily think in the context of a cultural background. So I like to kind of frame this by saying, all of us in doing the work that we do around school mental health is we pay attention to emotions, and we pay attention to thoughts, and we pay attention to behaviors, and we design our interventions to solve problems that are associated with any of these domains. But my bias is that the cultural context is the lens at which people view the world. And if that's the way that we view the world, then we're much more likely to be successful in the interventions that we do, because we will apply it to the context in which a person is living. So as I move forward, I will share a couple of things. One is why we want to do cultural adaptations. And then I'll talk about what models exist for doing so. And then how, like, what are some ways that we can do this work and not make it too far from what we have been trained to do. So let's start with the why we want to do cultural adaptations. One of the things that we want to think about is what are the benefits to the treatment that we do? So one thing we know, and the literature has shown, is that it improves the cultural compatibility, meaning when a person is from a cultural background that may be different from the original design of a particular intervention, and we're not included in the evidence base as that intervention was designed, it may not be compatible with their cultural values. So if we think about how to build a way of integrating culture, then it's going to be much more compatible to the outcomes that we're looking for. It has better ecological validity, meaning your treatment that you're doing as an individual will also be more applicable in other settings when you aren't there. So it expands, or it is much more able to be applied in outside that context. And then the clinician will have more opportunities for addressing the unique needs of the client when we are doing cultural adaptations. Obviously, the benefit to the client is that it integrates their own experience and their values and the coping mechanisms that they already use. And it also gives a place for experiences with discrimination to be included in the work, because we don't naturally do that. We also know that by doing adaptations, it increases treatment acceptability to clients of color that come in. They are much more likely to retain and stay into treatment because they accept it as meeting their needs and fitting within their context. And then last, it increases the generalizability beyond the actual session of an intervention. And benefits to the clinician is it helps show your own cultural competence and enhances rapport much more quickly. And then I have some citations down below. So as part of this, what are some general things that we should be doing? And these are the most general points here. We should be designing interventions within a cultural context. We should be employing intervention procedures that are appropriate for a target group, meaning the individual person that we are working with, as well as their community. We should be addressing within group variation. And what I mean by within group variation is that if you are working with someone of a diverse cultural group, you also have to recognize that some of the norms or values or assumptions that we know about that culture are going to vary with people within that group. So you have to start with your knowledge and then adapt it based on what you can learn about an individual within that group. And then finally, you want to attend to acculturation before making any interpretations. So of these things, some of these words, you may be like, I have no idea how to do that, but I will talk you through what I mean by that when I go through the next couple of sections. So as I mentioned, I would shift and kind of identify what are some models of cultural adaptation and what goes into making these treatment adaptations. So here's 4. There are more than this, but just to show, I want you to see the names. They're really long and mostly acronyms. I also want you to see the dates of these, that many have existed for some time, and many folks have not necessarily been taught directly how to do cultural adaptations because there has been a history of kind of perceptions that if you were to do any adaptations, that it would reduce the integrity of an evidence-based intervention. But all of the literature now suggests that that is not the case, that it actually enhances the acceptability and feasibility and even some of the treatment outcomes. So the one I'm going to pick to talk through with you next is the last one, the Ecological Validity and Cultural Sensitivity Framework. So EVCSF framework by Bernal et al. In 95 is when it was developed. There are 8 elements. of this model, and they are really focused on areas that you can address when you are looking at the intervention that you have designed to work with an individual. You want to pay attention to all of these elements. So first is language, that you want to make sure that the language is appropriate and culturally syntonic with the population that you're serving. The person, you want to know or pay attention to the role of ethnic similarities and differences between the client and the clinician in shaping treatment. So that is you and the person that you're working with. You want to make sure that you recognize when there are differences and adjust around that. And I'll talk you through some techniques for that. Content, you want to pay attention that you have knowledge that is cultural knowledge for the client so that you can make decisions about the content that's covered in treatment. Metaphors, using metaphors that are appropriate for the cultural group. So symbols, concepts, examples. You always know when you use a metaphor that may not fit, when somebody gives that glazed over look, like I have no idea what you're talking about. You want to make sure that they're definitely applicable to their life. Concepts, treatment concepts, making sure that they're consistent with the culture and the context that they're living in. Goals, positive, adaptive, including cultural values, but not imposing new values. And then methods, you want to make sure that you are using cultural enhancements of treatment methods and context, that you want to pay attention to the economic and social context of the client. So I'm going to walk through in the strategy section a few examples of adaptations in the domain of person, content, context, methods, and goals. So strategies, how do we do it? This is the number one thing that most people ask, because especially if we are doing like manualized interventions, we know exactly what we're supposed to do in a manualized intervention. And the second somebody says, do an adaptation, you kind of feel a little out of sorts. And so I'm going to give you some suggestions and techniques. So person, that first one, remember, this is the one around recognizing cross-cultural differences. So differences between yourself and the client that you're working with. And one of the core ways to do this in the beginning is to pay attention to things like communication styles. So I love this table because it kind of gives you an example of the ways in which we communicate may differ. And I would like for you to kind of, as you're looking through these categories, so on the left, you'll see the style of communication, the eye contact, the ways and the patterns that we use to speak, our response speed, and the intensity. Looking at those things and think about yourself. And think about the ways in which you're most comfortable in communicating. And then see if you can find yourself somewhere along this continuum here. Now notice along the top, it says culture A, B, C, D, and E. There actually are labels that go with different cultures, but I think that that's not really important here. I think what's more important is to recognize the variation that you can see and notice if you are looking and you recognize your own like communication style, and then also notice the ones that don't fit you, like the ones that are really kind of uncomfortable when you're interacting with someone that uses that kind of communication style. So an example might be, if I tend to be a person that uses, a lot of eye contact when I am speaking, but then when I'm listening, I don't give as much eye contact, but I'm communicating with someone that has a really indirect gaze when listening or speaking, I might wonder at times if they're listening to me, because I know what my style is, and I would have the expectation that they do the same thing. But that's not the way that we can interact when we are clinicians working with clients, that we have to lean into other cultural styles and give room and space for them. So kind of see this and recognize you may not fit in a vertical column. You might be mostly in one column and partially in another one. The same goes for your clients. And so the idea is kind of look at these different characteristics and recognize where you are uncomfortable with a person, because then you'll be more in tune to recognizing that you don't want to misinterpret their communication style. That's what this is for. Another example, this section is method, that you want to alter your approach to start with a good sociocultural history. So I developed something years ago as part of a research study where we were looking at 2 different approaches to doing treatment. So CBT and culturally responsive CBT. And one of the things that we tested was using an interview approach at the beginning of culturally responsive CBT to see if it differed in the ways in which the client and the clinician connected and the way that treatment proceeded thereafter. And in this study, what we found was those that use this interview schedule here and ask these interview questions rather than a standard kind of protocol approach to doing an interview, that they had greater connection. The clients were feeling that there was greater depth and breadth of treatment. They felt more understood, and they stayed in treatment and we didn't have attrition. And so some of these questions, what you're going to see in this is there are questions on the right side. Then on the left side, I asked Pamela Hayes, this a woman that wrote the book. It's on the second page of this, her book, the Addressing Cultural Competencies and Practice, a Framework for Clinicians and Counselors. She had identified the addressing framework as a acronym that you can use to categorize these things. And so I asked her if I could apply the GEMIS questions to the addressing framework and to give it a better structure, and she agreed. And so what you'll see here, these are questions that you can ask to get at the sociocultural history of a person much better than you can if you were asking just standard questions about development and developmental history. But I want to draw your attention to some of the questions under the ethnic and racial identity section. These are often questions that people that are in cross-cultural counseling relationships may feel a little nervous or uncomfortable about, and that is solely because of the way that our society has kind of shaped what's okay to talk about and what's not, so the taboo things. But I really strongly ask that you really look at these and then ask them. Ask these questions because oftentimes it changes the way that treatment goes. And so I'll give you one example. The question, I had a former student that was working with a family. She was white and the family was Black. And I was watching their sessions and they were not getting very far. And part of the reason why they weren't getting very far is because there was a lot of withholding from the clients, and they would give little kind of tips, but not enough to really go into a topic. And so I asked my former student to say the question, how does your race affect your relationships with other people? And when she did, the mom, her shoulders dropped. The child, the young man, he looked up and he said, "My teacher hates me." And so when you think about that question, there was no connection to school. It was, how does your race affect your relationships with other people? The mom's shoulder dropped and she said, "I'm so glad you asked that." And then he responded in that way. What it did is it shaped the treatment there forward, because suddenly he was able to talk about racial issues and dynamics he was experiencing at school. And he did it because my former student gave them the context to know that it was okay and it was safe to talk about things that are perceived as taboo. And so if you are not familiar with some communities of color, they're socialized, their children, they are socialized and their children are socialized not to talk about race or discrimination with people outside of their race. But if you, as the clinician, come to the space and offer a knowledge and a safety for being able to ask these questions, it creates the context for them to be able to move into domains that other people may not be able to support. So this second page is just continuing on the rest of the categories there. So you'll see that it's not my phone, is that? Okay, so there, if you kind of look at the bottom, there are 3 citations there. 2 of them are studies that use the GEMIS and that changed. We can see the way the treatment progressed based on these, using this tool. So that's one tool. Content. You want to know the culture. You want to know at least basics about the culture. And so I'm going to just give you a little image to kind of have in your mind. I'm a visual person, if you can imagine that I have all these pictures here. These categories are domains of knowledge that any person that you're working with in mental health, you should know about them. You should know something about their values and their perceptions and their beliefs. You should know something about their strengths and their supports. You should know something about their acculturation style, their acculturation conflicts that they've experienced, and the context at which they live. You want to know things about their environment, and you want to know things about adverse childhood experiences, the family members, as well as the child or adolescent that you're working with, because that shapes a lot. So in that, I don't have a lot of time to go through all of these, so I'm going to do what I can to hit just a few. This one always is a topic of interest to folks, and that is acculturation. One of the things that a lot of people will do is use the term acculturation and assimilation, and they will conflate them and connect them as if they were the same thing. And I like showing this graphic to show that they are absolutely not the same thing, that the concept or the construct of acculturation is one thing and assimilation is a strategy of acculturation. So what acculturation is it is the concept that's related to when a person has a cultural perspective, and it's the process by which they change when they're influenced by contact with another culture. So their behavior, their style, like all things, sometimes emotion will shift based on contact with another culture. So I want to describe each of these four, and I'll be kind of quick about it. So notice that there are arrows and there's a horizontal plane and a vertical plane. If you go across the horizontal plane, what it is considering is the preference for adopting a new culture. And then if you go along the vertical, it's the preference for keeping Native heritage or maintaining their Native identity, cultural identity. On the left side, assimilation, notice that there is a preference for adopting a new culture, but there is not a preference for maintaining or keeping their Native heritage. So assimilation is more adopting who's in the majority, behaving in that way. Separation is the opposite. It is maintaining the Native heritage and identity and not adopting a new cultural identity. So really staying fixed and more traditional in that culture. Then integration is more of a bicultural perspective where there's kind of fluidity, and maybe you'll hear things like code switching that occurs where a person can interact in one culture in one way and then differently in another, and they can fluidly move back and forth. And then individualism or marginalization, that version is where a person does not identify with any culture and they feel like they're very much an individual. The research has shown that assimilation and individualism are the two where there's the most acculturation stress, where a person experiences the most stress, because in assimilation, they're giving up their Native heritage. In individualism, they're not connected to anyone, that those are the two most concerning. So you want to kind of have an idea about acculturation when you're working with a person, because you'll know where their stressors are lying because of the strategies that they're using or they're feeling compelled to use. A couple more things. So context, let me go to context. Here, we want to pay attention to the social and ecological context that they live in. So let me give you some things to consider in there. What's happening here? Car thief or lost keys? We interpret this event based on our experiences. We have limited information. We had no sound. We didn't have any context. We were just observers. So what we do is we align with what's familiar. With limited information, we usually perceive a situation negatively if a person is pretty different from ourselves. So what happens is the situation doesn't really make sense to us, and that other person becomes an other. The reason why I show this is because I like to use this as an example of implicit bias. These are culturally based assumptions that we make in a millisecond, and they guide our behavior. And what they are, they're shortcuts that our brain creates so that we can process complex information efficiently. We're hardwired to fill in the blanks. So you might feel bad if you saw that and thought that he was a car thief. And that's solely because our society has primed you for that by portraying Black men as criminals. But what you can do, doesn't matter if that's your first thought, you can fight against implicit bias by intentionally filling in blanks by seeking information, additional information before acting. So for me, when I saw that video, I was actually surprised before I bought it because it was labeled car thief, but I thought he had lost his keys because I had an experience much like he did, had a car like that with the same kind of locks and locked my keys in the car. And I kept coming back and looking for the keys in the same spot, even though I'd been there 6 times and it wasn't appearing. But the reason why I thought that is because of the last gesture that he did. I don't know if you saw it, but it was, he like ran his fingers across the window as he walked away. That signaled familiarity to me. So that piece of data is what I was cueing into. And so that's the kind of thing I'm asking you to think about with clients that you have, is recognize that we all have bias and our brains do these shortcuts, but you want to recognize that some people experience this in their context where other people have perceptions of them related to bias all the time. So when we think about people that we're working with that experience racial oppression, there's some concepts you want to know about. So implicit bias, I like showing that video, so kind of remember that. Microaggressions, this, the terminology I'll talk about in just a moment, stereotype threat, and then another concept called attributional ambiguity. But I'll go through that. But the first thing is I love having people understand that microaggressions are when we say things that we don't intend to be harmful, but it comes in our communication. That's where microaggressions show up. What happens with us is when we have bias, that it's just sitting there and we're not really attuned to it, we might say things that we don't intend to be considered a microaggression, but that actually hurt other people. The academic definition of a microaggression is really these brief, everyday kind of exchanges that send denigrating messages to certain individuals, and it's because of their group membership. And what these statements do is they kind of affirm stereotypes about a person, and they're usually subtle insults. They're usually subtle. So what we do is we may make a comment, and then the person that experiences microaggressions regularly, they know that they're unintentional by the deliverer, but what they feel like are these tiny little cuts to the receiver. So one small microaggression may not be that bad, but then when they start compounding. You want to recognize that if you're working with a client where they're living microaggressions every day, they're experiencing life as having their identity devalued. And you want to make sure not to feed into that. And you want to make sure to give them a space to be able to talk about those challenges and experiences. Another term, it's not moving there, okay, is stereotype threat. So when a person has repeated experiences with implicit bias, remember those automatic shortcuts that our brains do, they learn how stereotypes are applied to them. And what happens is they start to feel powerless in shaping their own identity, and they learn that there's limits to what they can control. So think of an example of when implicit bias occurs, they experience this uncomfortableness and this fear of confirming a negative stereotype. So when they do that, some people respond differently. There's a couple of potential responses to stereotype threat. You have this fear. Some do the opposite reaction or behavior. So they want to prove they are not that stereotype. Others will just passively accept the assumption and just be like, well, they think what they think, I can't do anything about it. And then some will even give up and enact the stereotype. And what they're doing is they're trying to take ownership of it and take control over it. But all of these responses, they're subtle. They're all happening in their brains, and they take up a lot of headspace. And that process impacts development, it impacts growth, and it can even impact or hinder academic achievement. So kind of think about these concepts, implicit bias and microaggressions and stereotype threat. is really manifestations of discrimination that affect a person of color internally, and they're not going to easily share it in a cross-cultural counseling relationship unless you give them the space to do so. The last one, this one's kind of vague, but it's really exactly what it looks like. Attributional ambiguity. It just means that it is more, a person is much more likely to wonder, is that happening because I'm Black? Is that because I'm a woman? Is that, they're getting into this space where they're trying to make sense of things. And so you want to create the context for them to be able to work through that and talk through it. Okay, just have a few minutes left. So goals. We want to make sure that our goals are positive and value-oriented and strengths-based. Oftentimes when we develop our goals, we create goals that match the opposite of whatever the problem behavior is, or the problem emotion, or whatever the topic or the reason for referral for treatment. You want to make sure that you integrate values and strengths into those, because it gives you a place to start. And so on these two slides, and you will have a copy if you don't already, so I won't go through all of them, but these are ideas of personal strengths that are culturally related that you may not think about. So kind of think about that, like the second one where I say the ability to code switch, where you can apply group norms based on the context. Linguistic ability to be able to shift back and forth between languages in seconds. I mean, those are gifts. That is an incredible strength, and the fluidity at which a person's mind can work and connect their emotions is really powerful. So kind of recognizing these things that we take for granted or we don't really assume to be really healthy strengths. Even culturally related knowledge and practical skills like fishing, hunting, farming, knowing about medicinal plants, knowing about being a biblical scholar, like things like that. When it comes to family, recognize that these may be coping mechanisms that they don't necessarily talk about with everybody, but you create the context for them to talk about it and you can apply it. Same goes here for interpersonal cultural supports. You want to think about what are ways in which there are supports that are already established that can help to carry forward the intervention that you've done when you are no longer working with them. And so here's some examples that you can see. So storytelling activities that make meaning can be really powerful. Those can be the metaphors that you use as part of your adaptations to the interventions. So we got a general point that we want to make sure and remember that any therapy or intervention is not about the tools. Most of the time, it's really about the safe, trusting relationship that allows people to become unstuck from old patterns and be connected in a way where vulnerability is safe to move forward. So just here, key elements when you're just summary of culturally responsive interventions, that you want to be intentional, complete this puzzle. You want to build emotion regulation skills, but in the context of relationships with other people. You want to use psychoeducation as part of psychoeducation. You want to partner with BIPOC youth and families in understanding their symptoms, but separating the symptoms from their identity. And you want to do it in the cultural context. Strengths-based, I already described that you want to apply individual strengths as a foundation for interventions, because that gives you a launching point to keep moving forward in a positive way, and maximize relationships. So recognizing that most communities of color are interpersonal, they're very collectivistic, and they foster engagement with other people. So I will make this transition to Dr. Trevino, and she will focus on integrating cultural responses of approaches to treatment.
Thank you so much, Dr. Jones. So I'm going to go ahead and share my screen so we can transition here. And I just want to thank everyone for being here on a Friday afternoon. So again, I am Cindy Trevino, and my goal with this topic that I'll present on is to just build on the research and information that Dr. Jones has already kind of laid the groundwork for us on, and really just more so share how I've implemented these models for cultural adaptation in implementing evidence-based programs with Hispanic families, and specifically thinking about Spanish-speaking families, because that's a population that I work with clinically at the hospital. And one thing I just want to say before starting is that, you know, similar to Dr. Jones, this is an area that I'm really passionate about as well, both clinically and research, trying to develop some research work around this area as well. But clinically, I think, you know, my heritage and background is of Hispanic Latino heritage. You know, I speak Spanish, I'm bilingual. And so this is kind of my background that I'm thinking about as I bring in, that I'm bringing into the work that I do with families. And so I think that's important to kind of mention, because as I dive into the work and how I've thought about evidence-based programs for this population, I think going back to the topic that Dr. Jones mentioned about our own personal biases, I feel like going into this work, that was one of the things that I always was trying to be mindful of, right? It's like, I know the cultural and upbringing that I had in my own kind of parenting experiences, what my family kind of shared with me, what were the values that were shared with me. And I think they were important for me to recognize as I was going into this work, because I wanted to be mindful and careful that I wasn't imposing those values and beliefs that I had about parenting or the culture that I was brought into the work that I was doing with these families. And so what I'll do today is share essentially a case study of an evidence-based program and how I've kind of adapted certain things as I was working with Spanish-speaking families or Hispanic families in our community. So my objectives here are to do three things. One is to provide just a brief overview of culturally adapted evidence-based parent training programs, and then discuss more of the clinical application that we can use using the frameworks that Dr. Jones has mentioned, including the ecological validity and cultural sensitivity framework. And then also briefly talk about a process model. So this model, the cultural adaptation process model, is essentially the name of it, that really just talks about how we can adapt how we can adapt interventions or programs. And then the ecological validity and cultural sensitivity framework can really give us the lens to think about what might we be adapting. So the what, essentially. And then the third thing is to highlight just some of the challenges and the lessons learned that in this process of adapting and implementing a parent training program for Spanish-speaking families. So I know there are quite a few clinicians and just folks who are coming from a mental health background. So I imagine that this will be somewhat like information that most of you are already aware of, but I just want to make sure that we're kind of all on the same page of when I refer to parent training programs, what I'm essentially referring to is programs that are designed really to provide parents skills to respond effectively to their kids' behaviors and to try to kind of address any challenging behaviors that might be coming up in the home or elsewhere. And I would say that most programs really tend to focus on using praise, child-directed interaction as ways to encourage good behavior in the home. And then they also teach parents skills like, limit setting, how to give effective consequences to help address child misbehavior. And some of the programs that I've listed here on this slide are just some of the, I would say, most common evidence-based parent training programs that are out there. And of course, each of these different programs really focus on different ages, and then each of these programs has a different style of teaching each of these different topics. And I wanted to just share this here because one of the programs that I'll talk about specifically and how I was approaching it when I was thinking of adapting it for Spanish-speaking families is the Incredible Years program specifically. But before I get there, I want to just briefly share some of the literature that has been published on each of these programs as far as whether or not they've been culturally adapted for different communities. Because when I was thinking about using an evidence-based parent training program with Spanish-speaking families, I was trying to think about, what has already been done, what's already been published by other researchers in the field, and what are some things that I might be able to draw on. So this here is a table. from a systematic review that was completed by Bauman and colleagues. The citations down here below if people are interested. And she essentially did a systematic review where she looked at a lot of different articles, specifically on parent training programs, and looking at these articles and diving into, what did they culturally adapt? And she was actually using the ecological validity and cultural sensitivity framework that Dr. Jones shared with us just a few minutes ago. And she really kind of looked at what were the different things that, these researchers had looked at, that they had adapted. And so here on the right-hand side, you can see that we have the four of the evidence-based parent training programs that she looked at. So one of them was parent-child interaction therapy, and she was able to find 3 PCIT articles that had been culturally adapted for. There was no specific population for which she focused on for the systematic review, but essentially she just looked at adaptations across different populations. She also looked at the Incredible Years program, the parent management training model, and then also the positive parenting program, so triple P. And what she found in her search was that there were about 3 articles that had been published where they culturally adapted PCIT. There were 4 articles where they did report culturally adapting the PMTO model, and then 1 article where they looked at triple P and the process that they went through to culturally adapt. Overall, across all these articles, what they found was that most commonly when they were doing a cultural adaptation to these programs, they did tend to address language as one of the factors. So they either translated materials or they were able to essentially have the materials accessible to the families in the language that they needed them. The other area where they tended to do the adaptations were the metaphors. So for example, in a program, if there's ever like examples or sayings or expressions, or even the name of the program, for some of these articles, they went ahead and kind of adapted some of those things to really fit with the target population, so the population they were really trying to focus on with the program. They also adapted content, and what they mainly kind of adapted when they were looking at the content specifically was like the session structure, if there was social or political kind of issues that were going on at the time, kind of really tying them into how they might relate to parenting. They may have slowed down the pace of the program or material in the way that it was being delivered, and also kind of adding in more opportunities for families to share personal stories. And then the last one was the method. So either increasing or just decreasing the amount of time that they were needing to deliver content. So across all these different categories, each of these different programs kind of targeted one of these and adapted them. What I was most struck by when I was thinking about again implementing a parenting program with Spanish-speaking families was that there were no articles that had been published at the time showing kind of a cultural adaptation model of the Incredible Years program, which again is a very well-known evidence-based parent training program. And I guess the caveat here is that within the cultural adaptation criteria that was used for the Bauman article, there were no studies that they again included or they could identify as having adapted in any of one of those 8 areas from the ecological validity and cultural sensitivity framework. That aside, though, there are several articles by folks who developed the Incredible Years program where they have looked at implementing the Incredible Years with diverse racial and ethnic communities. And so there was, a study from 2001, way back, in the day when they were looking at the acceptability and effectiveness of the Incredible Years model. And they did actually implement the IY group in a Head Start setting with low income kind of Asian, Hispanic, and African American families. And from what they found from that study was that the program content and then the delivery was actually acceptable and useful for the families that they were implementing the program with. But there hadn't been, again, as I mentioned, any studies that had looked specifically at the adaptation of this program. So that's kind of what led me to think more creatively about how can we take this, evidence-based program, Incredible Years. At the time when I was thinking about adapting this, I was also, finishing up my postdoctoral training. I had gotten training in the Incredible Years, and it was a program that I was, well aware of, had been able to kind of co-implement or co-deliver with another colleague of mine at the hospital. And I was kind of going through several questions in my mind of, if this is a program that I'm going to implement with Spanish-speaking families, what should I be considering? Are there any adaptations that I should be making before thinking about delivering it with Spanish-speaking families? And so I want to just draw your attention to a couple of questions that I think were relevant for me at the time when I was thinking about these things. And when I was doing the planning ahead of time of trying to offer this program for Spanish-speaking families in our community. I should preface by saying that, at the time also that we at Seattle Children's, we weren't doing a very good job of serving Spanish-speaking families as a whole. There weren't a lot of groups that we were offering in that language. I think if families were referred to us for treatment, they were often, being given individual therapy via an interpreter. So this was going to be, a program that I was going to try to offer to families in that language, in Spanish, in a group format. And so I wanted to be very careful about what are some things that I might be wanting to change or adapt to make sure that it fit with the families, and that I was also really just interested in thinking about retention and, would families come, would they stay, would they be able to complete the group? So the things that I was considering at the time where, what is the evidence about the intervention that's available? So, like I mentioned in that systematic review earlier, I was looking at articles that had been published on, this specific evidence-based program, the Incredible Years, with Hispanic families, with Spanish-speaking families. And I was thinking, who was this program or intervention developed with? And thinking about, has it been implemented with a target population that I'm interested in? And then I was also thinking about what was the target domain of the intervention. So the Incredible Years was primarily developed to address challenging behavior. So I was thinking about, will I be able to have families who are having these concerns, right? Come through the door and be interested in a program like this. And then the other questions that I was thinking about at the time were, is the evidence-based treatment accessible to the providers who will be delivering the intervention? So in this case, that was me, right? Did I have access to the materials that I was going to need? Where the materials already translated? And then I was trying to also think about the underlying mechanisms that drive the intervention, and thinking about whether or not this would be a good fit for the population that I was interested in, right, with Spanish-speaking families. So thinking about how is the program designed, what are the components as part of the program, what are the topics that we might be talking about. So in the Incredible Years program, for example, there's a lot of information around play, child-directed play, praise, ignoring, timeout, rewards. And so I was thinking about all of these different topics and thinking about what does the literature say about these strategies and the acceptability from the standpoint of Latino Hispanic families or Spanish-speaking families. And then the last one was thinking about the evidence-based treatments and whether or not, again, they're acceptable for this target population. So as I was kind of going through and answering these questions, based on the literature, I had some knowledge that there wasn't a whole lot as far as published articles that they were demonstrating the adaptation process of the Incredible Years with Spanish-speaking families necessarily, but I already knew at the time that those materials were translated. And so kind of the next steps, in the next couple of slides, what I'll share is just the process that I went through to thinking about parts of the intervention that I thought might need to be adapted to fit more the patients and families that I was interested in working with. And again, that group of Spanish-speaking families. And so I essentially kind of took two cultural adaptation frameworks in mind. One, they would give me the information of what I might want to adapt. And so here I'll again reference the ecological validity and cultural sensitivity framework. And then I also needed essentially a model to help walk me through the process of how I might be adapting it. And I should preface this also by saying, like, this is something that I was doing more clinically, like in my work. I didn't necessarily have any like research funding or any funds that I was using to kind of carry out a study necessarily. I think it was more of me trying to think about how can I do this clinically and have it be something that's that could be meaningful and also super relevant to the families that I was interested in working with. So briefly, here's the cultural adaptation process model that has essentially 3 stages. So here on the left-hand side, you can see that they're setting the stage. And here, what this model kind of outlines is you want to kind of start off first by reviewing the concepts and strategies and thinking about how they might fit with the population that you're interested in. The other piece that you might want to consider at this stage too is also, assessing the community need and then evaluating based on that information of, what are some things you might want to adapt. The second stage here is the initial adaptation. So here you want to be thinking about what are some things that I can tailor or adapt in the intervention ahead of time. And then you also want to be thinking about what are some measures that can help me, understand whether or not this information that I'm presenting is culturally appropriate for the family, it's going to be acceptable. And then the third step here is just the adaptations and iterations. So after you have a chance at implementing the intervention or the program, that you can either get some information or some feedback from families and then think about how you can be making iterative changes to that program to just better fit with the family that you're working with. So this can happen in iterative phases as you're kind of implementing it. So I'll just kind of walk through each of these different stages and share a little bit about what I was doing and what I was considering at each of these stages. So with the setting the stage phase, one of the things that I was trying to do early on is, do a deep dive into the literature on just broad topics. Since I didn't have articles that were necessarily referencing adaptations of the incredible years with Latino families and Spanish-speaking families, I was more trying to zoom out of that topic a little bit and trying to think about what does the literature say on Latino mental health, Latino parenting, what are some other intervention research that have been done with this population, and then what are some of the studies out there on culture and parenting in this population. And one of the things that that stood out to me in kind of that literature search was that there was a lot more research, I would say, on the culture, understanding kind of the culture and values of Latinos in general, and their and the more common values associated with this community, like, for example, having a sense of respect between people in the family, personalismo, meaning that this emotional connection and kind of personal connection with people is really important. So those were some, those are some of the common ones. There's other cultural values as well, like simpatía, and a few others. And again, so I wanted to kind of get a layout of the culture and background for this community. And part of my lit search in this area was, I was kind of thinking and bringing in, again, my own implicit bias, my own understanding of what the Latino Hispanic culture included. And I was kind of reading these articles and thinking, oh, yep, I understand these values, or these are things that I remember kind of in my own upbringing. But then I wanted, again, the lens of thinking about each family as an individual. And so I'll talk more about in the next slide about how we can essentially do, as part of our interview or assessment with families, to get a sense of what their cultural values and beliefs are, because again, they could be very variable even within a culture. But then the other thing that really stood out as part of the literature review was that there was also high acceptability among Latino parents for use of positive reinforcement strategies. So using things like social rewards or like praise, but there was lower acceptability for things like ignoring. So that really was going to influence how I was going to think about presenting different strategies or techniques as part of the program. And then the other two areas here where, I at the time, I knew that we weren't getting a lot of referrals for Spanish speaking families. So I was really interested to learn from the community, both community organizations and community leaders who were already serving this community and thinking about what were the needs that they were identifying for, the Latino population, the Spanish speaking population, and how we could be thinking about, or how I could be thinking about that if I wanted to bring them in to participate in this program. So I was talking with folks from the ARC of King County, folks from the UW neighborhood primary care clinics in Kent, Des Moines, trying to think about, trying to just get a layout of the community. And then the last step here was reviewing, of course, the translated materials that I had access to and making sure that the translations made sense, that the information that was getting delivered, kind of the verbiage and the wording that was being offered in these materials was going to make sense and seem relevant. So in this kind of second phase, which is the initial adaptation process, I essentially used the ecological validity and cultural sensitivity framework that Dr. Jones had mentioned earlier. And of course, there are several different factors here that you can kind of consider for adaptation. And for this kind of example that I'm sharing with you today of adapting the Incredible Years program, or this parent training program, I specifically focused on 3 of those. The first was language. So I wanted to make sure that the information and the materials that I was presenting to families was, of course, was available in Spanish, and that the information would make sense to families. The other one is, of course, the person who was delivering the program would be, either a native Spanish speaker or be Spanish speaking, so that we could deliver the information firsthand to families. And of course, in this case, I was the person kind of leading this effort, and so I was able to definitely take care of that second point there. And then the second one is I was thinking about the content. So I was thinking about what are some of the values and customs that families might be bringing in to this to the treatment, and thinking about how I can be incorporating some of their values as part of the program content. So ahead of having families participate in the group, one of the things that I did was have a consult visit with the group leader and also the families that were participating in the program or that were signed up to participate. And what I was doing is essentially asking them a variety of questions to get a sense of who the family was, what were some of the challenges that they were having, what are some of the things around their parenting that they really valued or that they thought they were doing really well in, and what were some of the things that they were wanting to change. And so on the next slide, I'll share a little bit about what that kind of interview included. Because one of the things that I found to be really helpful is I wanted to get a sense of, as Dr. Jones mentioned, we want to get a good kind of sociocultural formulation of the family. And so by asking a variety of different questions, I was able to kind of do that, is essentially get a picture in my mind of what was important to the family, what were the things that they were struggling with or having challenges with, what were things they had tried before, and how is that all going to fit in with the information that I knew would be presented as part of this parent training program. And then the last one was the method. So the way that we were delivering the intervention, there were a couple of things that we were going to change. So one is that, the Incredible Years program is traditionally designed as an 18-week program. But what I kept hearing from our community partners was that the time commitment could be a challenge for families. A lot of families in our community would potentially be working, long hours or would have variable work schedules, and committing to an 18-week program could potentially be challenging. So what we ended up doing is essentially adapting the program to be a bit shorter, to 8 weeks. And then we were still keeping the amount of time that the program was intended, which is typically a 2-hour program per week. And then the next point here is that we also allowed inclusion of extended family members. So if parents had other caregivers in the home who were taking care of their kiddos while they were at work, whether it was grandparents or aunts and uncles, we were essentially opening the invitation to have other family members participate. And then the last thing that we did here was offered the group after working hours. So traditionally, a lot of our outpatient group programs at the hospital had been offered within the 8 to 5 working hours. We knew that was probably not going to be as feasible for families, so we ended up kind of shifting things a little bit and offering it in the evening hours. So this here is just an outline of essentially kind of the breakdown of the topics that we covered and in the order that they were covered. One of the things that we added here is just we offered individual sessions for families in between transitioning from more of these positive discipline approach strategies to doing more of the disciplinary strategies down below. And this was just informed from the literature from what I had been reading that some of these strategies may come maybe more acceptable to Latino Spanish-speaking families, less so the ones at the bottom. So this would give me an opportunity to kind of check in with families and see how things have been going with the other strategies. So this is just a brief kind of layout of the engagement strategies, I guess you could call them, to essentially trying to figure out what were going to be the things that the families kind of were bringing into treatment. So a couple of things that I was keeping an ear out when I did those consult visits was assessing family kind of attitudes and beliefs about what was challenging to them. What were some of their treatment expectations, right? Both of the outcome and then past experiences, and then also their motivation for participation. I was also kind of looking at what their parenting style was. And a lot of the questions I ask around that are, what are some things that you like about your parenting? What are some things that you are hoping to change or would like to change about your parenting style? And then I was also kind of assessing more of the family or social supports for the family and asking some questions also about, the family's cultural background. So I was interested to know like where they were from, where they were, how long they've been here. So to give me an idea of, what things were important to them, how long they've been here, what were some things that they were kind of adopting as far as this culture or things that they were bringing in from their own culture. And then based on this information, I was essentially weaving it into the parent training portion of the program. So I was giving them families opportunities to share more about their own parenting experiences. And I was also providing bringing in the goals that the families had shared during those consult visits as part of the program delivery. I was sharing, how the strategies could fit in with the family's goals. So this is just kind of a brief picture here of some of the data that I collected as part of the group, mostly just on acceptability. So how helpful was the content and information that the families were receiving? And overall, it was mostly positive, that they found the strategies to be helpful. But of course, like with any program that we implement, there are many challenges that can come up. So for a lot of the parents that participated in this group, the first round, we had a lot of barriers that came up around like travel distance, childcare availability, the parents' work schedules, and retention was of course poor for our group. So it wasn't perfect despite trying to make changes and adaptations to the program. And I think that, of course, was attributed to just a lot of factors that that the families were experiencing. And then the last one here, when I was delivering this program, it was in person. And so when families didn't have childcare, they were often bringing them into group sessions. So managing that in the room was kind of challenging at times. So then here, I just kind of want to outline the adaptations and iterations that were made along the way. And one, I would say the things that I learned from this is just that assessing engagement early on is important, getting a good understanding of the family's kind of background, because that's really going to inform how we're delivering the program content. We of course adjusted the length of the group. That worked really well. The day and time the groups were offered seemed overall, we got good feedback from the family about that. Since the delivery of this program, we've adapted it, and we're now offering things more over telehealth. And we find that the attendance is a lot better in that sense, because we serve families from broader regions. And so travel is not as big of an issue if we're able to offer it over telehealth. Providing opportunities for families to share personal stories and examples seem to be a good way to kind of tie in what we were talking about to the families' kind of own personal experiences and own histories with their own parenting. And so we shifted away from implementing more of a evidence-based program like the Incredible Years and transitioned more to using evidence-informed parent training materials, because we found we were not necessarily, meeting the full 18-week model as it was designed in IY, but essentially kind of moved toward creating a program that would fit more of the still same strategies, but in a briefer version. And overall, I think what we learned from this process was that there is just a higher need for services in Spanish with Spanish-speaking families. And so that has really led to this next piece of my work, which was mentioned briefly at the beginning, that right now I'm really focused on really expanding mental health treatment for Spanish-speaking families, and so this is where the work in the Comma Clinic has developed, and I'm happy to talk more about that if people are interested. But I just want to say that work kind of really led to the development of this clinic. And with that, I'm going to transition us to hopefully some questions.
Perfectly on time. Thank you so much to both Dr. Jones and Dr. Trevino. Those were incredible presentations. So now I think we'll just pivot to Q&A. And so if you all just want to take a moment to put any questions you have in the chat, we'll just start I will be moderating, we'll share them with our presenters, and we can just have, the next 10 minutes to chat about any questions you have. And feel free to specify who the question is for, if it's for someone specific. We'll just give folks a second to write questions in the chat box. Okay, so it looks like I have a message from, it's a direct message, so not everyone can see it, but Paul Davis asked for you, Cindy, if you have any thoughts on cultural considerations for telehealth that you're aware of around adaptation or generally.
Yeah, that's a really good question. So, well, I can speak clinically to my experience. So one of the things that I have found in doing a lot of I focus more on doing parent-based work, and it's in a group format, and we typically use Zoom as the platform for delivering these programs. What I find is that a lot of the families I'm working with are, again, primarily Spanish speaking. A lot of families are joining in from their phones. So if I have any content that I'm wanting to share via my screen, for example, I try to not heavily rely on that like screen share function necessarily, because I find that the families can't necessarily even read it if they're accessing it from their phones. So what I've resorted to is essentially just having things mailed to the families ahead of time for the group, if it's materials that I'm able to share. And then I briefly may show an image of it so the family knows what page or thing I'm referring to. But then I just end up doing a lot more face-to-face. I remove the screen share so the family can see me, I can see them, and then I'm sharing information that way. I find otherwise, if I spend too much time in the screen share, I lose that personal kind of touch connection with the family. And then if they're joining, as many families in my groups are, from their phones, then they can't even see see me or connect with me anyways. So I would say that that is one strategy that I have found that maybe seems simple, but it has worked really well for the families that I've worked with.
I would add that adding captioning if you're doing telehealth via Zoom, it's so that the translation comes in native language. That is extremely helpful for engagement and connection.
Wonderful. Thank you both. And I think this question can be to either of you. We have a question from Michael, and they asked, what are some helpful questions for therapists to use to broach issues of culture and race in session?
So I just dropped in the GEMIS table, the slide that I had with the framework. So on the right side of that, it includes questions along all of those dimensions of the addressing framework. And these are where they came from so I was in private practice for 14 years, and everybody that I was seeing in South Seattle was mostly families of color, and they were questions that I was asking naturally, but didn't really have a structure for doing it. And so then, I just started writing them down, like, what am I always wanting to know when I'm asking people? And so that's how that really came about, because these were the things that were most relevant to the families that I was working with. So thanks, Rebecca.
And I would say, Dr. Jones, that I still draw on some of that, the GEMIS and the addressing framework. Like I may not have it in front of me, but I feel like once I'm familiar with the questions, it's things that I'm able to kind of bring into the room when I'm seeing patients and families. Like, oh, I know what areas to talk about, and there's a few questions that I know off the top of my head that I can then ask in the moment. So it's a really helpful resource.
Great. Thank you both so much. I'm not seeing any other questions in the chat, but we'll give folks a little more time. If you have any other questions or just general reactions or thoughts, feel free to put those in there. All right, another question from Michael. Thank you. What are some common mistakes clinicians make when trying to adapt treatments? I think both of you probably have thoughts on this.
Well, I'll throw out one. Being too afraid to push boundaries, I think, is the first mistake. I think that we get really caught up in our rigid kind of approaches to evidence-based treatments and don't trust our own clinical judgment, in that we can vary because of the people that we're seeing, and trust that you will not destroy the integrity of the intervention if you adapt to the person that you're working with. Like, you getting to that giving yourself permission, I think, is kind of the first thing that gets really difficult. And then the second would be, I didn't mention this when I was talking about the asking the questions that are more taboo or feel more taboo, that part of the resistance to doing so was because they were uncomfortable as a clinician, being uncomfortable asking things that were harder to get at because there were assumptions that they were raised to think that it would cause someone else to think badly of them. And so having to push yourself past that and recognize that this is for the client, not for myself, that this is about them and their needs. And even if I'm uncomfortable, it actually is probably the right thing for them. So those two, I think, are big.
Yeah, I can't remember where I heard this, but somebody once shared with me, like, you want to have flexibility with infidelity, right? So I think that's the part that we're talking about in terms of cultural adaptations, is that we can make adaptations to what we're delivering and still stick within an evidence-based framework or model of the program. So I just want to second what you said, Dr. Jones. I think that's definitely one of them.
Thank you both so much. So I'm going to put in the chat an evaluation form. I just want to get that in there. I know that folks, it's getting late in the evening, and so I just want to put that in there for folks to start filling out whenever you have a chance. So any final questions or any kind of, I don't know, final thoughts or remarks from you both before I think we can kind of transition into our end. So I just want to thank everyone so much for being here and for all the thoughtful questions and engagement, and a huge thank you to our amazing presenters. So we'll now kind of transition to the end, and feel free to stay on if you have additional questions and want to ask Dr. Jones and Dr. Trevino any additional thoughts. We have a few more minutes. And as a reminder, this is a 4-part series. So part 3 is next Wednesday, December 7th at 1 p.m. And that is focused on family interventions for adolescents. So we hope you'll join us. And again, as a reminder, this webinar will be uploaded on our website at uwcolab.org if you'd ever like to rewatch it or share it with folks. And you'll also receive a follow-up email with that link and with the post-evaluation survey. So thank you so much, everyone. And the slide deck will be sent out with their contact information as well. So thank you again for joining us, and I hope you have a wonderful and restful weekend.